And now it's my pleasure to introduce Dr. Fergus, who is one of our cardiologists here at the Mount Sinai Heart, and she's going to be talking to us about lipid guidelines in therapy. So please join us in welcoming Dr. Fergus to the stage. Thank you so much. This is this way and backward.
And where's the pointer?
I believe this is the pointer.
Okay.
This is the pointer? I know, but the pointer. No, it is. It's on here. There is. I don't know if it's that.
Or maybe the mouse could be the pointer.
Or the mouse.
There's
Mouse
a laser
or
pointer should be this right here.
Which one?
Right here.
That one?
that one.
Thank you.
Okay.
All
Thank
right,
you.
thanks.
Thank you.
Well, good afternoon, everyone. I'm glad you guys did Jeopardy before, so it kind of woke everybody up because lipid, discussions are a little bit, kind of intense and, a little hard. So I hope you can follow along with me. So today I'm going to talk a little bit. I have no financial disclosures or relationships to disclose. And I want to talk to you about the lipid guidelines recommendations, discuss the benefits of lowering LDL, pharmacological therapies that improve CVD, recognize and understand the role of alternative or additional therapies, and talk about adverse reactions to statins. So we're going to start with a question, keep this in mind, and see if you can get the answer, see if it's correct later. In addition to being placed on a statin, which of the following treatments has been shown to reduce risk of cardiovascular events? 1, niacin, 2, fenofibrate, 3, cholestyramine, 4, ezetimibe, 5, none of the above. What do people say? It's okay, so I can't tell you the answer yet. So we're talking about this because the annual rates of all the cardiovascular events are really staggering, with myocardial infarction, strokes, CVD mortality, very, it's like over $1 million over a million events. Every 30 seconds, there's a death. And cardiovascular cath, it's over 1 million. And percutaneous revascularization, surgical revascularization, the cost is staggering, over 315 million. So that's why we intervene. Now, this is also very staggering. The vast majority of patients do not receive adequate LDL testing between recurrent events. And here we're comparing Mount Sinai with the nation. And Mount Sinai does a little bit better, but between testing, only 27.7% of people actually get follow-up LDL-C testing appropriately. So you have, in Mount Sinai's case, 72% of them that don't receive testing, but it's worse for the nation, where 80% or so are not getting testing and only 19.8 or 18% getting that. So hopefully after this discussion, you'll be testing people more because it's an issue. So the guidelines advocate for a multifaceted approach to manage lipids, focusing initially on primary prevention, but also secondary prevention. And the main thing that all of the guidelines talk about is lifestyle is the number one, okay? And the reason is because cholesterol effects cumulative throughout the lifespan. So continued treatment and evaluation are recommended. So these are the guideline, this is the guideline algorithm. And I know you guys are looking at it like, oh my God, it's a lot. So I'm gonna break it down very, very simply. You have the guidelines for primary prevention and secondary prevention. Now, primary prevention are those who do not already have some sort of CVD occurrence, right? They just have the risk factors. And essentially, they're all getting lifestyle intervention first, and you separate them into age groups to manage whether or not they're gonna be on statins. Secondary prevention, they already have had an event like an MI, a stroke, some sort of PAD. And again, it starts with lifestyle. And basically then you separate them into high risk and age, less than 75, greater than 75. And then in the very high risk groups, what you're gonna know is that you need to start a high intensity statin. And I'll break that down a little bit more. But first, let me show you the sort of prevention events that considered secondary events, okay? So I talked about already having ASCS, which is acute coronary syndrome, having a history of MI, stroke, or peripheral vascular disease. The high-risk conditions are age over 65, heterogeneous familial hypercholesterolemia, which I will talk about in a little bit more detail. Having had a bypass or diabetes is a risk equivalent. Hypertension, CKD, smoking, and having elevated cholesterol despite maximally tolerated therapy and heart failure. So these are the statin benefits groups. Feel free to take a picture if you would like. It's available for you. So adults 20 years of age or older and a candidate for statin therapy. If they have clinical ASCVD and they're age less than 75, yes, they need a high-intensity statin. This is Class A recommendation. If not, and their LDL is greater than 190, they're going to get a high-intensity statin. If they can't tolerate, these patients then get moderate intensity. If they don't have that and they're a diabetic and they're between age 40 to 75, then they get a moderate intensity statin. If not, and they have a high ASCVD risk, who here calculates ASCVD risk on patients? Raise your hand. Yes, no, maybe so? Okay, so in clinic and you calculate an ASCVD risk, if it's high and you're between age 40 to 75, then you get a moderate to high intensity statin. And then if not, then you want to measure these risk factors at least every 4 to 6 years and recalculate the ASCVD risk in those with high risks. So clinical pearl number 1, even though statins are robust LDL lowering drugs, there's significant inter-patient variability. That means that everyone responds differently to statin, and this slide shows that, basically showing men and women where you could have 0 response to a very significant response. So recognize that, and you have to re-challenge patients to know that. So this is patients on atorvastatin 10, where you see that there's this significant variability, but it has been shown in other groups as well. Why is that important? Because poor response to statins is linked to CAD progression. Looking at several trials, the risk factors did not differ, but LDL-C does. And what happens is that those people who don't respond, they actually show a greater progression in atheroma volume. That means they're going to have more CAD, more stenosis if they're non-responders. So that's very, very important to recognize. So non-adherence, right? We have, sometimes people are not responding because maybe they're not taking the medications and you don't know, so you got to ask that question. But actually, when you put people on statin, they're typically non-adherent. And by 6 months, 50% of people are actually not taking their statins very well, okay? So, and it continues over time, so you need to actually, ask patients. And why do people not adhere to statin therapy? I'll talk about that. But I'll show you that here, that if people are not adhering to statin therapy, guess what? They're twice as likely to experience a subsequent myocardial infarction. The first, right here, this is the total. You see that the non-responders, the non-adherent versus the adherent, those who are adherent, half as likely to have an MI. And if you separate them into age less than 65 and greater than 65, those who are less than 65, they're 3 times more likely to have an MI compared those who are non-adherent compared with those who are adherent. So it's more apparently important for the younger people, and the older people not so much. But basically, if you're non-adherent, you're more likely to have an MI. And I said the reason that a lot of people don't take it is because they're statin intolerant. But it's only about 5 to 20% of people who are statin intolerant. Commonly, it's muscle pain, aching, and weakness, right? That leads to discontinuation, but you've got to check your patients and figure out what is really going on, because they can, in many cases, be, re-challenged. So clinical pearl number 2, many patients labeled as statin intolerance can be re-challenged with a statin. However, there's a real subgroup of patients who are truly statin intolerant. So typically, myalgias, those are the most common. Up to 10,000 people per 100,000 have myalgias. But true myopathy and rhabdomyolysis are a lot more rare, okay? So what are the factors that increase the risk of statin-induced myopathy? So on the left, the patient characteristics are here. So increasing age, female sex, okay? Renal insufficiency, hepatic dysfunction, hypothyroidism, diet or meds, and polypharmacy, and also vitamin D deficiency, which is not mentioned here. And of course, the statin properties, so the older statins that are more high potency are more likely to cause effects. Some of the newer statins, like fluvastatin and pitavastatin, not so much. So this is a question here, okay? Which of the following strategies is least likely to decrease muscular side effects when you're on statins? Adding coenzyme Q10, decreasing the statin dose, switching to nighttime dosing, switching to alternate day dosing, substituting red yeast rice. What do you guys think? All right, let's discuss it. So the next slide, okay, listen. If there is severe muscle symptoms or fatigue during statin therapy, stop the statin, okay? And you gotta rule out rhabdo, all right? So you're gonna check the CPK, the creatinine, and urine for myoglobulinemia. I said severe muscle. Now, if it's just mild to moderate symptoms, you'll stop the statin until the symptoms are properly evaluated. And you wanna check for other conditions. But if after 2 months off of the statin therapy, and you still have muscle symptoms or elevated CPK, it's probably something else. And the conditions that I'm gonna mention here may be contributory, so you gotta rule them out. Hypothyroidism, renal or hepatic function, rheumatological disorders such as polymyalgia rheumatica, steroid myopathy, vitamin D deficiency, which is why I check vitamin D on all my patients, or primary muscle diseases. So if you stop the statin, they're still having symptoms, make sure it's not some other thing like that. Because again, if they don't take the statin, they could have an MI, all right? So I promised you I would talk a little bit about FH, and I have a lot, so I know I'm talking fast. But guess what? FH is actually the most common inherited disorder. Did you guys know that? It's 4 times more common than sickle cell anemia, sickle cell disease. And it's 5 times more common than cystic fibrosis. So when you think about all the sort of genetically inherited disorders, familial hypercholesterolemia is the most common. So it's a heritable autosomal dominant disorder. It's due to a mutation that affects the LDL receptor, also including sometimes the ApoB gene and the PCSK gene. And it manifests with severe hypercholesterolemia. And why is it important? Because it makes CVD occur earlier in men, like between age 42 to 46 years, women 52 to 52 years old. It's underdiagnosed and undertreated. You have about 600,000 people with this disease, but only 10% are diagnosed. And a high potency statin is usually not enough. So clinical pearl number 3, it's common, 1 in 500 patients. So you want to, there's actually a guide, like sort of a recommendation, the WHO Dutch Lipid score that gives you an idea if these patients have FH, okay? So family history, 2 points. Tendon xanthoma, do you guys know what that is? It's like you touch the back of the tendon down here on the heel and also in the hands. And if you feel like deposits of cholesterol, that's tendon xanthoma. That gets 6 points, okay? If you have an LDL cholesterol of over 190, that's 3 points. And if you have an AUCUS, if you've had it, you know what's an AUCUS? It's like that little round circle around the eye, inside around the conjunctiva. That's called an AUCUS senilis. And it's an indicative if you have high cholesterol. So when you have points that are greater than 8, then you most likely have familial hyperlipidemia. Okay, and why is it important? Because over time, you're going to have a cumulative probability of having CVD or CAD. So very, very important if you for you to diagnose and treat. So the statins, okay, here's a table that tells you the statins, what's high intensity, moderate intensity, and low intensity. The 2 high intensity statins we have are atorvastatin and rosuvastatin at maximal doses. So here, now we're going to talk about insufficient response to statin therapy. So that is you're not getting to goal despite maximal therapy. And so this is when you want to consider adding another statin, non-statin cholesterol-lowering drugs. So clinical pearl number 4 is to add non-statin if the person is high risk and you're not getting to goal, looking at the adverse effects, okay? So I'm going to just very quickly, this is Zetia. This was studied in the Improve It trial, over 18,000 individuals randomized to simvastatin versus simvastatin and ezetimibe. And they followed them over 2.5-year follow-up. And actually, the primary endpoint was death, MI, coronary revascularization, stroke, and bleeding. And the ezetimibe simvastatin combination actually reduced the LDL a lot less. And by 1 month out, you could see the reduction in LDL with the simvastatin alone down to 69, but with the Zetia and combination with the simvastatin down to 54. And that persisted over time up to 96 months. PCSK9 inhibitors, right? You've heard of, I can't even pronounce them, alirocumab and evolucumab, all right? We're using those. There's another one that we don't really use as much, and we use them in in the clinic. Very, very important. So very briefly, what happens, this is a schematic. What typically happens is that you see the LDL receptor here, this little squiggly thing. This is the PCSK9. That's the lipid molecule. They bind together. They go into the cell, and they get taken up into the endosome. And people with FH, the receptor gets degraded, so it doesn't come back out to capture more LDL particles. And what the PCSK9 inhibitor does is it inhibits the PCSK9. And so it doesn't allow that breakdown of the receptor, so the receptor can go back out to the surface and remove the LDL particles. That's simply what it does, okay? And so very, very, very potent drugs. So the Odyssey trial showed this in over 2,000 patients who had LDL that persisted at 70 mgs despite maximal therapy with statins. And they may have had like a Zetia attached as well. And they were not getting lower than 70, so they were randomized. And what happens is you'll see that the line in red here represents standard therapy, and this is with the PCSK9. And you'll see a significant drop in LDL by 61% down to 43, even after 4 to 5 weeks. And that persisted throughout. You see the big difference, right? Being on, the PCSK9 inhibitor. Very well tolerated, minimal side effects, LFTs and CPK, no difference. And following these patients out, it persisted. You'll see a reduction in cardiovascular deaths and also tolerating very well. The same thing occurs with the evolucumab. So I know we talk about, so this is Repatha, right? And Praluent. So you see the same thing. Let me just go back. With, with the evolucumab, with a significant drop early on that persists and very minimal side effects. One of the side effects may be neurological. People get like a little mentally impaired, but other than that, you're not having the liver and all that other stuff going on. And the GLACOV trial actually supported that and shows a reduction in atheromatoous plaque. And also shows that if you have an LDL above 70, you're going to continue to deposit plaque in your arteries. So that's one of the reasons we try to get the LDL down. So that question that I asked about being placed on a statin, the following treatments that has been shown to reduce cardiovascular deaths, obviously PCSK9, but out of all of these, they may help to reduce your cholesterol, but the only one that I showed you with the addition by itself or an addition on top of a statin is ezetimibe out of these ones that are listed here. Okay, so you want to follow people when you're treating them. You want to follow them 4 to 12 weeks after starting therapy and repeat every 3 to 12 months as needed. Very important. Brief word on lipoprotein A. That's the big sexy thing that everybody's talking about right now, lipoprotein A, little a, and I hope everybody measured theirs, but it's an LDL-like particle that's attached to apolipoprotein A. They're covalently linked. And it can either be prothrombotic or it could be antifibrinolytic, okay? And accelerates atherosclerosis like LDL. So you want to measure at least once for intermediate or high-risk individuals or family history and or elevated LPL-a. Also, if you still have recurrent CVD despite statin therapy or a high ASCVD risk, all these people need to get their LPL-a checked. I got mine checked. So basically it shows that, guess what? Lifestyle interventions has no effect on LPA, neither statins. So you might say, well, what do we do? Well, niacin and lipoprotein apheresis can help, but now we're finding out that the PCSK9 inhibitors, including the long-acting one, inclisiran, can help. So they can actually reduce the lipoprotein A by 50%. So inclisiran is what we're using now in GP1 Center. It's a small interfering RNA inhibiting type of the PCSK9 protein. And this one lasts very much longer than some of the other treatments. So once you get the patient started on it, they come into the office and they get an injection every 6 months. And you're actually seeing a reduction by 52% at day 180. And this was studied in the Orion trials. Another one that you may have heard of is bempedoic acid. Anybody heard of that? Nexletol. It's a non-statin. It could be used as monotherapy or on top of other drugs. If people are not getting to goal, if they are intolerant of statins, then this is one that you could use. And then triglycerides. It's very bear with me. I have like 2 or 3 more minutes, then I'm going to be done. So why is triglycerides important? Very high levels can give you pancreatitis, okay, over 500. And it's relatively easy to manage. This is one that you can manage with lifestyle. So you want to get very low-fat diets, glycemic control, and then you could use things like phenofibrate niacin fish oils. And remember, those don't give mortality benefit, but the statins do. And then we have a new one that you all probably heard about, which is icopacent ethyl or Vasepa. You've heard of Vasepa? And it's a high-purity ethyl ester that you take 4 grams per day. And it's an adjunct to diet to reduce triglyceride levels. It's approved for people who are greater than 499, or if you can't get their triglycerides down. Very important, try to get the triglycerides down before doing LDL lowering. Supplements, very quickly, because everybody takes supplements, because all the patients say, I don't want the statin, I'm going to take supplements. Well, this sport trial was discussed at the AHA, the last AHA in the fall, and it compared low-dose rosuvastatin 5 to these supplements, which are fish oil, cinnamon, garlic, turmeric, plant sterols, or red yeast rice. Sound familiar to you guys? A lot of people take that. I'm not telling you not to take it. But the outcome of the study is that Crestor, simvastatin 5, reduced the lipids by at least 21%, 21 to 23%. The only other thing that did something was the red yeast rice, which reduced by 7%. Okay, so the other ones were like neutral. So I'm just letting you know. It also helped to reduce triglycerides as well. Calcium score, very quickly. You want to do a calcium score for people who are intolerant to statin, don't want to start statin, who you don't know what to do, you get the calcium score, okay? And if the calcium score is elevated, they need to be on lipid lowering. For women, calcium score is important, but also carotid intimal medial thickness, so you want to do a carotid Doppler, because this one study showed that people had 0 calcium score, and when they did the carotid Doppler, they had plaques, okay? So I do both on all my patients, especially the female patients. So that's the end. These are the top 10 takeaways. They're highlighted, okay? Everything I just said in 10 sentences, but or 10, statements. But I'd say 6 of them are very, very, very important, and they're all important, but I want you to remember, emphasize healthy lifestyle across the lifespan. That's 1. Number 2, if you have ASCVD, you want to reduce LDL with a high intensity statin, maximally tolerated. So you keep up titrating till they can't tolerate it anymore. And then you want to try to get to a threshold of less than 70, especially if they have high risk. So with this, you want to add other non-statins like the PCSK9, Zetia, et cetera, to that. In patients with an LDL of greater than 190, you don't even bother to calculate the ASCD risk score. It's high, and you get started on a high-intensity statin. So if you do a LDL, it's greater than 190, don't ask questions, just start. And then here at the bottom, 40 to 75 years without diabetes, LDL-C, you kind of don't know what's going on. That's when you get a calcium score, okay? And then, of course, you want to repeat for adherence and non-respondents, like they're not responding. So you want to repeat the lipids 4 to 12 weeks after starting initiation or adjusting the dose, and you repeat that every 3 to 12 months as needed. And there you have it. Thank you very much for having me today, and I hope you learned something.